YouTube, before we jump into the video, make sure you check out my Patreon account. It's designed for serious medical aesthetics providers just like you.
How are you?
I'm good, Dan. How are you?
I'm excellent, thanks. Amazing to see you. Nice to meet you. How is MCAS?
Very interesting. It was actually amazing to catch up with, like-minded, down-to-earth colleagues, as I said in my post. But there was another side of aesthetic medicine which was clearly apparent, and something I discussed in the post as well. Alienization and the kind of things I'm sure we'll talk about.
Okay, so before we begin, for people who aren't aware of Dr. Harris, I don't know if you've been under a rock, but he's definitely one of the UK's leading practitioners in the field of medical aesthetics. He's actually a big advocate and lecturer that speaks regularly about body dysmorphic disorders. He's also recently had a publication about alienization, which is the unnatural look, this very unnatural, over-dramatic look in medical aesthetics, and how you're a big advocate on keeping things very natural. And at the same time, you've treated over 40,000 faces over your career, which is very impressive. And I'm very happy and honored that you took the time to join us here in chat today. Thanks so much.
Thanks for inviting me, Dan.
My pleasure. Okay, so first question is your dissolving clinic. I would like to know more about this dissolving clinic. Is it your practice that you open up at part of the day, or is this like a separate clinic, or want to discuss that a little more in detail?
It's in the practice. I call it the dissolving clinic. Actually, I call it the normalization clinic more because it also involves new treatment. So dissolving and new treatment. It's part of my regular clinic. But I gave it a name just to make people aware of it and to just help those who need it, really. But I spend a lot of my time dissolving and doing corrective work, as I think you do too, don't you?
Yeah, we do a lot of dissolving here, and we get a lot of questions about it. And it's nice that we have open conversations, because on one of my YouTube videos, I did post about sometimes the rare complications if you have to flood a face or if you have to flood an area with hyaluronidase. And that sparked some type of trigger where people thought that, hyaluronidase is dangerous. It's not dangerous. It's just there's a very small percentage of people usually who are a little bit more mature and have had a lot of filler, have expanded a lot of their tissues over the years. And then once you dissolve that, then it's kind of like a balloon, which is just deflated. You're not only dissolving the hyaluronic acid in the gel, but you're also going to temporarily dissolve your own hyaluronic acid. And that's not only in the skin, it's also in the SMAS. It's everything, and it takes a little time to come back, and sometimes it doesn't fully come back. And I kind of explain to clients, whereas if it's someone who's, let's say if you gain 200 pounds over 10 years and you decide to lose it rapidly, you're going to have soft, wrinkling skin and sagging skin. There's not too much you can do about that other than surgery. But if someone's gained 50 pounds over a year and it's only been the year and then they dissolved it, they'll go back to normal and that should be fine. So in most cases, it works very well, and I rarely have any issues with it. But I just, letting people know that it's not 100% foolproof. And I would like to know your opinion on that.
I agree. And we have to understand that fillers in themselves are not inert. And as you say, the kind of problems we see are from overfilling and the fillers most likely, rather than the hyaluronidase, which is an enzyme and substrate specific by definition. And so it does not dissolve your own tissue. It's specific to hyaluronic acid, and as we know, there is a regular turnover of hyaluronic acid in the body, so that your entire stores of hyaluronic are turned over every few days, so it's replenished. We sometimes see the effects of dehydration or some discoloration from hyaluronidase, but largely it is safe.
So for you, how many clients do you think you're dissolving a day, and is this something that you're opening, once a week, or just blend it into your practice? In the UK, is this something that's becoming more and more frequent where you're having to dissolve a lot more fillers?
I would say yes. And I think this is true for a lot of practitioners. And there are more and more clinics opening, certainly here in the UK, specific for that purpose. I've blended it in to my regular clinic. So, I could dissolve up to 5 cases a day.
Wow.
And a few days a week. So it's quite busy, and it's something I do fairly regularly. So I would say I have a fair amount of experience with it, and I feel comfortable using it.
If a client comes in and they have overfilled lips, or it's definitely migrated because of maybe frequent injections over a short period of time, if they're coming in and they're asking for you to dissolve it, do you recommend a full dissolving and then retreating the lip, or are you an advocate for partially dissolving, and have you had success partially dissolving on top of the border?
Yeah, I've heard of the partial dissolving. I think Julie Horn mentioned that during our conversation. It's not something I do because I find that it's very difficult to control how the enzyme spreads and dissolves. So I find that it's easier to dissolve what needs to be dissolved rather than try and dissolve in some sort of using some sort of system to dissolve parts of it. Is this something you've done? Do you find success with it? Just sort of isolating the area?
Yeah, I started it with tear troughs. So if someone comes in and they have a little bit of tear trough, that's just migrated to the surface, then I've actually had a lot of success just putting, 5 to 8 units in that little area, and it does a great job of calming it down. They don't need to dissolve the whole thing. So I thought of doing it to the upper lip. And the way I did it was I just made sure, because it disperses. It's not very accurate. It's just going to kind of spread out. So I just make, wherever I see the border or the migration of the filler, I go maybe 2 millimeters above it, and I'll just place a little bead around there and use a cannula. It does a pretty good job. Once in a while, I will have to kind of tweak it with a little bit of filler. But for people who are very hesitant in just dissolving all of it, then I'll try that first. But it is 50-50. It's kind of something where I'll try out. If it works out, great. But if it's still, in my opinion, it doesn't look good and they're asking me to fill it more, then I won't. I'll just recommend dissolving, come back in 2 weeks.
Yeah, so it can be a bit unpredictable. But yes, I can see that perhaps it needs to be looked at more closely for sure.
I would like to talk more about your discussions and your lectures about body dysmorphia disorder, body dysmorphia. That was really interesting when I read that. And I would like to know specifically, do you have any tips for providers who are clearly dealing with a client who comes in with body dysmorphia with regards to medical aesthetics? They can't see that they're overfilled and they want more, or they're pushing for something. And how is your approach? How do you approach that?
Yeah, it's a really difficult one because as a general rule, I think it's a very bad idea to treat someone with suspected body dysmorphic disorder, because clearly this is a psychological disorder rather than an actual physical thing going on. And they really need psychological intervention rather than being filled with fillers, which they end up being very dissatisfied with anyway, and can cause a deterioration in their mental state. And we have to be very careful with these patients because they have a very, very high suicide rate and significant comorbidity with severe depression and other disorders. So I think it's very important to, if you suspect someone with body dysmorphic disorder, to really try and, shall we say, psychoeducate them in terms of what's going on. And what you can do is ask them to rate the severity of what they perceive as the problem and then provide your own rating to see the discrepancy. And that could be an opening way to discuss the issue with them. And I think then really what one should do is not just sort of let them go, but bring them back for a follow-up appointment when you would discuss maybe referring them for psychological help. And the things that work quite well with body dysmorphic disorder are cognitive behavior therapy in combination with SSRI type antidepressant medication. And they seem to do reasonably well on that, but certainly aesthetic treatment is not the solution, and you're going to run into a lot of problems if you go down that route, because they, as I said, can become very dissatisfied and want to take you to court, etc., etc. It can be a very, very difficult situation for both.
I haven't had to deal with many, fortunately, but it is very tricky. And it's difficult to pick up because there's a lot of people who are just have an attentive eye. And they look well, they look great, but you're always wondering, is this a body dysmorphic disorder? Because I'm having a hard time seeing what they see, and they look perfect.
Yeah, I think that's a clue. But I think you need to establish how much this interferes with their day-to-day living and prevents them from doing things, going to work, social interaction, that kind of thing, and how much time they spend preoccupied with their perceived defect. So there are certain questions you can ask to sort of,
Do you do body dysmorphic disorder kind of like a screening tool? If you feel that potentially a client comes in, is there like a checklist, like a questionnaire that you'd have them ask, or you'd ask them?
Yeah, there are questions that you can ask. Basically, they do involve establishing how much time per day they're preoccupied with the problem, whether they engage in safety type behaviors, and whether this interferes with their day-to-day living in terms of social interaction, establishing interpersonal relationships, and how much it interferes with work. So there are questions along those lines.
So I think that's basically it. I appreciate you taking the time. This is lovely meeting you.
No, it's really good to meet you too. Thanks, Dan. I appreciate that.
Okay.
All right. Cheers for now.
Take care. Take care, everyone. Thank you.